All right. Again, we'll let a few more people in here before we officially get started. Hopefully where you're at, you're nice and warm. I know where I'm at here in Waseca, Minnesota, it is rainy, which is very different for February. So I guess we'll take any moisture we can get. But all right, we're going to get started here. So thank you so much for joining us today. My name is Julie Tesh, and I am President and CEO of the Center for Rural Policy and Development. And we are extremely happy and excited to present to you today our latest report on rural mental health and the workforce with rural mental health. And I'm so appreciative to Minnesota State Mankato for partnering with us, allowing us to partner with them on this report. I'm really hoping that a lot of decision makers and a lot of media pick this up because it is such an important topic. We all know that mental health is very important, but we need mental health workers in order to work with mental health patients and clients. So very important topic today. I will quickly mention before I hand it over to Marnie that this is being recorded and it will be up on our YouTube channel within the coming 48 hours. So feel free to share this, have people go to our YouTube channel, Center for Rural Policy and Development, and you can do that and subscribe to our channel. I'll also mention we are active on social media, on Twitter, on Facebook, LinkedIn, and soon to be Instagram. We're finally getting with the times on Instagram, so be looking for that. But let's see what else. Yeah, thank you all, everyone, for being here today. Oh, also, we will be doing questions. If you could do questions in the chat, we will be monitoring those and getting them to Marnie and the panelists as well. So feel free to send in those questions and we'll go from there. So without further ado, I'm happy to turn it over to Marnie Werner, our Vice President of Research and Operations. Welcome, Marnie.
Hi, thanks, Julie. Yeah, and thanks everyone for coming today. This is a report that we just released today that the center partnered with the Center for Rural Behavioral Health at Minnesota State University, Mankato. And we think it's an important report, especially after hearing all the news today about the rather grim statistics about youth mental health, especially girls, that was all over the news today. And of course, a lot of that has to do with just unmet need. We'll talk a little bit about that and the lack of workers. And so I'm just going to share my screen here, and we will go over the findings of the report that we have today. And so here's the mental health workforce shortage. And there is definitely a shortage. We have a shortage of licensed mental health providers everywhere, but especially in rural Minnesota, we have fewer providers and higher need. And as you can see from this chart on the right, over half of our licensed providers in Minnesota are over the age of 55, and a quarter of them are over age 65. So that means we have quite a few who are set to be retiring soon. And of course, the issue is who's going to replace them. The job vacancy rate, that's something that we talk about quite a bit at the center here. You can see over there on the far right, the job vacancy rate went from 8% in 2019 to 26%. So that means 26% of currently posted mental health and substance abuse counselor jobs are sitting vacant. A lot of this has to do with burnout, especially in the pandemic, and all those retirements that are going on. And so where are the counselors? According to the Minnesota Department of Health, 82% of them are in metropolitan areas. That's the 7-county Twin Cities, and then also the larger population centers like Mankato or St. Cloud or Duluth. 10% are in micropolitan areas, 5% in small towns, and 2% in the isolated rural areas. And you can see in this little table here, the ratio of providers to population. In metropolitan areas, it's one licensed mental health professional for every 197 residents. as you get down to isolated rural, it's one professional for every 741 residents. And yeah, you'll have to excuse my cat just came walking in. So we have what we're calling unmet need, which is basically the fact that there are services available, but there is not enough supply of providers to meet that increasing demand. And we see that again in the Minnesota Student Survey from 2022, where 29% of students reported that they suffer long-term mental health problems. And so here's one major indicator of unmet need. These are the suicide rates for different areas of Minnesota, different regions, and this is pretty much based on population density. The lines in the lower ones, these are all suicide rates for larger population areas, metropolitan, large fringe metro, which is the suburbs. But then you get up into the micropolitan areas, which are in greater Minnesota, the non-core areas, which is this yellow line here. These are the rural areas. And then this medium metro area, which is actually only 2 counties, but they're counties that happen to have a large population of Native Americans who unfortunately have a much higher suicide rate than other ethnic and racial groups in the state. And so this all shows up in the suicide rates. And so you can see everybody's rates are going up gradually, but they're higher and going up faster in the rural areas. And so rural Minnesota needs more counselors. And so these are the findings and recommendations from our report. And first, I'll talk a little bit about gathering information. So our chief authors were myself, and I wrote mostly about the workforce shortage end of it, the data and whatnot, the background to it. And then Thad Shunkwiler and Dr. Tracie Self from Minnesota State, they went out and interviewed licensed providers around greater Minnesota to discuss difficulties in attracting and retaining licensed professionals. And then they also surveyed colleges and universities with their master's programs that lead to licensed mental health occupations, talking about barriers to expanding programs and graduating more students. And so some of the findings were these. First of all, programs don't have enough faculty, and that limits the number of students that we can even graduate. So the recommendation here was we need more support for educational programs. And part of the problem there is accreditation standards, which are not the problem. They ensure quality for the programs, but it limits the number of students that a college or university can have in their program because of the number of faculty, the faculty to student ratio. In order to have more students, the college or university needs to be able to have more faculty, and they can't necessarily afford that, and that limits the number of students. And then you can see here, 2/3 of the programs responding said they turned away qualified students every year. And you can see on the right side, there were 2 programs that actually turn away more than 20 students every year. And so this really adds up quite a bit. And then 90% of them cited the lack of teaching faculty amongst some of the other problems. And here's a little more about the accreditation standards that assure quality. And so here, accreditation standards generally require a 12-to-1 student to faculty ratio in these master's programs that lead to licensure. And so taking on more students simply requires more faculty. And most of the colleges and universities said that they just can't afford it. And so the next finding has to do with pay, expectations of low pay at rural clinics and more pay at urban clinics, or even the cash only private clinics that are starting to develop. It disincentivizes students, especially when they start doing the math and looking at the finances of getting getting into a licensed mental health field and getting through the process of getting that education. Upfront tuition aid would be really helpful. Student loan forgiveness programs can be problematic. The problem here is that students have there's not just the 2 or 3 years of being in school. Once they graduate, they still have 2 or more years of supervised training. And during those years, they're being paid, but they're being paid a fairly low pay because they're not licensed yet. But at the same time, they're still paying on their student loans. And so it really becomes something of a financial burden that students may or may not be willing to take. They really have to be quite dedicated to the idea of entering this field to get through this. And so what we would like to see are solutions that would make it possible for students who don't already have, a lot of financial assets starting out to help them get through that without being just completely loaded down with student loans before they even get to the possibility of student loan forgiveness. And so here's a little of what I was talking about. You can see here at the start, you have the tuition, which is $25,000 to $50,000, depending on which program you're in. You have your coursework the first year. The second year, you have your coursework, but you're also doing a practicum. And then the second semester, you're doing an internship. And during both of these, it's not uncommon for either of these internships to not pay. Then you get to graduation, your student loan repayment begins, but then the next year, and probably the year after that, and maybe even an additional year, you're in supervised training, which is low pay. And then finally you get licensed after that, once you've completed all of that. And then you get to find out if you qualify for student loan forgiveness once you've started serving in an underserved population. So you can see how it gets to be a bit of a gamble to see whether that's even going to work for a student. And then another recommendation or another finding and recommendation, it's difficult to attract licensed workers to rural areas. We talked about that in the paper too, that trying to attract students to rural areas. But providers in the paper also talked about how having internships, hosting students in internships at their clinics were a really good way to get the students familiar with practicing in a rural area and just introducing them to the idea of staying. And it's been pretty well clarified and shown in research that students are more likely to stay and practice near where they interned. And so financial assistance to rural clinics is important because internships cost clinics money, especially the small private clinics. They're the doctors and licensed professionals who are supervising the students aren't necessarily the time they spend supervising students isn't necessarily getting reimbursed by the insurance companies or Medicare and Medicaid. And so there is money and cost involved in that for clinics. And then just getting students introduced to the mental health care field is a really good idea. High school and middle school is a good time, especially for rural kids, to get them introduced to the idea of entering this field and getting them thinking about it. And that there is a job that they can have in rural Minnesota and stay in rural Minnesota if they want to. And so it's a little more about what we talked about. The best strategy in getting new professionals to our clinic is to bring them on as students. Without interns, I don't know who we would hire. That was one of the professionals up in Virginia, Minnesota. And Karen Dolan in Marshall said that her clinic would absolutely consider taking on clinical interns if there was compensation for their lost service time. And we'll probably go into more with the panelists about how that exactly works and why why that extra funding is needed just to be able to host students for internships, because it's not like getting free labor. There is a cost to having students. And then finally, there's uneven reimbursement for Medicare and Medicaid. There's a pay parity issue where mental health, not all mental health fields are reimbursed by Medicare. Reimbursement rates are a federal issue. There's not a whole lot the state can do about it, but Medicare reimbursement rates influence rates by many other payers like insurance companies, whatnot. So there is an influence there. And then mental health is one of the lower paid fields amongst licensed healthcare providers, and that can be a disincentive as well. And so the objective here is the shortage is critical right now, and we would like to be able to help create a system where the financial math works for prospective students and for colleges and universities to see if we can free up those pipelines and start moving more students through and get more graduates and more licensed professionals out into the field to help with this demand that is really getting to a critical point now. And so that is what we have. And I am going to stop sharing here and turn it over to Kate, who will introduce the panelists.
Thanks, Marnie, and thanks to everyone that's joining us today. I'm so glad we can all be together virtually to discuss this really important topic. My name is Kate Raditz. I am with Park Street PR. We are a PR firm based in St. Paul, Minnesota, and we work with the Center for Rural Policy and Development. And so really, really grateful we can be part of this today. Prior to coming to the firm last year, I was a journalist for most notably almost a decade in TV in the Twin Cities, and worked in Green Bay, Wisconsin, and did some print journalism before that as well. So I'm always really happy to get to ask some questions and get some great answers from our experts today. So I'm going to ask our panelists who are on to go ahead and turn their cameras and audio back on. Make sure everybody is here and ready. I think I see all of them. And I will go ahead and start and ask them to introduce themselves. If you want to go around, we can start with you, Thad.
Yeah, good afternoon, everyone. I'm Thad Shunkwiler, one of the authors on this report that we're talking about. I'm an associate professor in the Department of Health Science at the beautiful campus of Minnesota State University, Mankato. I'm also the founding director of the Center for Rural Behavioral Health, whose mission is to ensure that every Minnesotan, regardless of zip code, has access to mental health services.
Great. Andrew?
Hi, my name is Andrew Larson. I am the owner and clinical director of North Star Counseling Center in Hutchinson, Minnesota, which is about 60 miles west of Minneapolis.
Great. Jinny?
Good afternoon, everyone. My name is Jinny Palen. I'm the executive director of the Minnesota Association of Community Mental Health Programs. We're a state network of 34 community mental health and chemical health programs across Minnesota. Great to be here.
And Tracie?
Hi, my name is Tracie Rutherford Self. I am an assistant professor at Minnesota State and also one of the authors on this report. And I am an affiliate faculty member at the Center for Rural Behavior Health. And I additionally have owned a very small private practice in the upper Midwest for the past 12 years in a community of about 5,000 people.
Great to have you all here, and you all heard from Marnie already. I'm going to start, I have a series of questions. I'm going to be mindful of our time. And if you have any questions, just go ahead and chat them in or in the Q&A section, and I will try to keep on an eye on those as well and try to get to some of those too. So I'm just going to jump in and we will start with talking about the mental health needs in rural areas and how they are different and similar. So maybe Jinny, if you want to start with this one, I'll just kind of bounce around and feel free to pass it on if someone's better to answer. How are the mental health needs in rural areas different, or how are they similar?
Thanks so much, Kate and everyone. I think that's That's a really interesting question, and I've gotten it a few times since I've been with the association. I think in a lot of ways the needs are very similar. We're seeing that folks more and more, there's a societal recognition of how important mental and chemical health are to all of us as whole humans, no matter where we live or what we do for a profession or what stage of life we're in. And so I think the needs themselves are not necessarily all that different. I think in terms of how folks are able to get treatment or have accessible care for some of those needs and the challenges that folks have, that varies quite a bit, I would say, between folks who are living in greater Minnesota and rural parts of the country and the state compared to folks who are in the metro and Twin Cities area. Most of the mental health centers that are part of our association work primarily with folks who are in the safety net. We're safety net providers. We work with folks who might not have insurance or on public programs or just don't have access to care because of where they live or their ability to pay. And what we've seen in a lot of our agencies in greater Minnesota is it's not just that they are the safety net and working with folks who wouldn't have access because of financial reasons or other reasons, but we also find that they're oftentimes the only provider available within a very large 5 or 6 county region sometimes. So it's that they're the only provider available in the region for folks to find some of these services, especially as we're talking about some of the more community-based or specialized services that go beyond outpatient therapy or psychiatry, which are important, but some of those other services that aren't quite as that are more community-based are not necessarily as frequently accessible as in the metro space sometimes. So I think the different challenges and the barriers to accessing care vary quite a bit when we're talking about folks who are living in greater Minnesota and folks who are in the metro area.
Thank you. Tracie, Thad, or Marnie, anything you want to add to that based on the report?
So in addition to the report, I would just briefly add the idea of acceptability. So when we look at rural communities, this is a completely different culture when we look at some of the more urban and suburban communities. And there's still some stigma attached to mental health in rural areas. So acceptability becomes a bit of an issue when we're working with that population. And we have to be able to go in and integrate into the population and establish validity of our services as well. And that can also inhibit individuals from coming in and seeking mental health services.
Thank you. So we know from the report there is a greater need for mental health care in rural areas, and it has to do with what's called unmet need, which means there are services, but that there is not enough. What is the unmet need in rural areas and how big is it? And maybe Thad, we could go to you on this one.
Yeah, thanks so much, Kate. Whether we call it unmet need or some language that I like to use is called the treatment gap from those who need care and those who can provide it. And we know statistically that gap is larger in more rural, isolated, greater Minnesota areas. And I think one data point that I like to reflect on that really tells this story in a very clear way, if we look at that Minnesota Student Survey data that Marnie referenced earlier, and so if you're unfamiliar with the Minnesota Student Survey, it's a survey done by the Minnesota Department of Education and the Minnesota Department of Health that takes the pulse of our young people in our public school system. And it asks them a lot of different questions about their health. And one area that it focuses in on is mental health. And we learned this last year back in December that the mental well-being of the young people in Minnesota has never been worse by any statistical measure. The great thing about that survey data, it allows us to drill down by county and to give the listeners and the audience just an idea of what this unmet need might look like in rural areas. If we go to Jackson County, Minnesota, it's on the southern border of Minnesota next to Iowa. You look at their Minnesota Student Survey data and you will find that 2/3 of the female identifying students in Jackson County report long-term mental health problems. When you look at the number of providers in Jackson County, you're going to get a big fat 0. There are no licensed providers in the county of Jackson using Minnesota Department of Health workforce data. So we have this huge need. We have, 2/3 of the young women, female identifying students in Jackson County saying, I have a challenge. I have an emotional difficulty that's been going on a long time. And yet there's nowhere for them in their county to go to. And so when you think about that unmet need, it's hard to give an exact number of what it looks like everywhere. But this report clearly lays out the evidence that there is this need in our greater Minnesota areas that we're just simply not able to address.
Tracie, do we know some of the reasons there is a greater need for mental health care in rural areas, or what they're facing?
So in general, we actually see higher levels of mental health issues overall in rural communities. And again, that's for a number of reasons. So we've kind of touched on some of the main ones: acceptability, accessibility, and availability are really the issues that kind of come into play. But again, the culture piece, because there's still a really patriarchal sense in a lot of rural areas, and this idea that we take care of ourselves and we take care of our own families. So they don't often seek out mental health services the same way someone who's been um, doing so in more urban areas. So it's not as acceptable. Again, there's a lot of stigma. And like one of the things that we know is people who come in from rural communities who die by suicide often don't have a diagnosis from a rural area. And that's because they've never had services and those services haven't been available to them. They didn't seek them out. There's a number of different things, but we really have to have available services. And again, so as that's talking about this one county, we're seeing that replicated against so many counties across the upper Midwest. It's a Minnesota issue, it's an Iowa issue, it's a Wisconsin, South and North Dakota. When I'm talking with providers in those other communities, we're all seeing the same thing, is that we don't have enough people who are willing to go into those communities. When we do have providers in those communities, they can't necessarily keep up with what's occurring in them because there aren't enough for them. They don't have enough time, they don't have enough availability. So there's, I think, this cascade effect where we don't have enough providers. We have people who aren't sure about going into rural communities, and all those things come together and really make it a difficult topic to deal with. Because if we're going to go into rural communities, we have to be present in rural communities. And again, that takes time that mental health providers may simply not have access to.
I see a question popping up. It's kind of a bit more of a comment, but I'll bring it up. It says, can you ask your panelists to talk about county jails as de facto mental health and chemical dependency centers simply because placement options often are non-existent? Does anyone able to comment on that?
Yeah,
Thad.
I can jump in on this one. The largest mental health treatment facility in this country is the Cook County Jail in Chicago. And so this, the question from Jack here is head on. We rely on the correctional system, whether it be jails or prison, to be de facto treatment centers. And often what happens is that people have underlying mental health issues. They're unable to get them treated. They exacerbate, they then have full decompensation. They end up, acting, having some behavioral challenge that involves the police. They end up in jail. And as someone who provided services in jails in southern Minnesota for about 8 years, I can tell you, they're not equipped to deal with the mental health challenges. And oftentimes people sit in jails getting worse. There's nothing about a jail cell that helps with their mental health issues. And if we think there's not enough providers in rural communities, there's not enough providers in any of those jails as well.
I see one more question I want to get to as well. It says Canada identifies workforce shortages by sector, then recruits for those needs worldwide. Could this be a possible solution here? Does anyone want to take that one?
Who would like to address? Oh, I was just going to say, who would like to address the immigration policy issue?
Well, I mean, even apart from that, the biggest issue is that people coming into the mental health field have to meet our licensure standards, and those are not necessarily the same across various countries. And in fact, in many cases, they're not the same at all. So I have a current student who is from Costa Rica, psychologist, licensed as a psychologist in Costa Rica, but is having to go through our program to meet licensure standards. So apart from even immigration issues, which I think is a whole other can of worms, I mean, just the licensure piece and having to meet the standards we've set forth here in the United States becomes really limiting for people trying to come in from other countries, because they're going to have to take additional coursework, go through additional internships and practicums, even though they may be very experienced and may be very qualified in other ways, because they haven't met our standards.
If I could, Kate, take a different angle on it, if I look at the question differently, if the question is coming from, could we focus our recruitment efforts into this workforce area? I think the answer of that is really, that's what this report is hopefully trying to do, is to make that call out there and say, we need to put more professionals onto this pipeline. And as we'll probably get to later in the webinar, once they're in that pipeline, we need to make sure the educational institutions that train them, that provide the training they need, have the resources to graduate more students. And so I think if the question is reading, could we be more direct in and intentional in recruiting people into this workforce? I think that process has begun and needs to continue. The challenge, I'll add, is it takes anywhere from 4 to 10 years to get a provider fully credentialed. And so it's not something that we're going to solve overnight. It could take potentially a decade for us to really see the results of this recruitment effort.
And we have seen some of that in Minnesota in the healthcare field. Didn't we cite a program attracting nurses in one of the nursing fields?
Yeah, so there's been longstanding programs to try to recruit new nurses, and they have the same capacity issues that we reference here. But even with the more the more recent shortage in nursing assistants, there's been a lot of interest in how do we quickly recruit and train people up in some of those disciplines. Once again, the challenge in mental health is just the amount of time that it takes to get somebody trained and credentialed is just it needs to start now.
I'll move on, kind of going off of that, talking about needing to start now, needing to start early. Andrew, maybe I'll start with you on this. How important is early intervention when it comes to this this struggle?
Good question. I think one of the big things that we look at in terms of, regardless of the modality of therapy, earlier intervention is going to mean that there's less time for a pattern to be established of whether it be behavior or it be cognitions, earlier challenges to that. Better results in therapy. So that clearly is one piece that I look at as being very critical, and it's very challenging again in rural communities. And it can actually go back to one question earlier about I live in a rural community. So I practice here. This is also my hometown. One of the pieces that I think that was really critical there is the idea of the mental health professional being and serving their own community. We at our clinic here in Hutchinson, there's another town close by, Glencoe, which is I think 15 miles from here, and we opened a place up there, and it took some time for us to get kind of established there, and part of it being because we were outsiders, even though we had one provider that actually is from Glencoe. It's so important, I think, that we have providers that not just understand, but actually are part of the community that they're serving. Otherwise, it's like these outside sources are coming in and influencing us, versus it being like, no, this is mental health that's being taken care of by the inside of the community itself. But that was one piece I wanted to go back to. I didn't want to interject earlier, but I think that's a really critical piece, is that we have people that are serving their own community in a sense, that being a critical piece in terms of people being accepting to those services that are being provided. So sorry, I derailed the question you had there, but that was one that really I saw as being really important. Early intervention for sure is a big deal, which again is a super big challenge in rural communities as wait lists are very long.
Does anyone else want to add anything when it comes to early intervention and what you've seen, or some of the biggest issues?
Yeah, I promise I won't answer every question, but I do feel pretty passionate about this one. This is what's so important about this topic, the timing of it correlating with that Minnesota Student Survey data. These 30% of our young people who are not doing well are not going to magically become adults and start doing better. And so we can see this coming down the pipe, that if we don't start intervening earlier with young people who are often a captive audience, we're going to have a number of adults who just won't have, we're going to have some challenges that our system currently is not equipped to address. So the earlier we can get to these issues, particularly with young people, the better chances that they will have in developing into adults without some of these difficulties and challenges.
In the report, it identifies 3 major factors that aggravate the unmet needs in rural areas. They are accessibility, availability, and acceptability. Marnie, maybe we can ask you on this one, talking about some of these. Let's talk about accessibility first. What are some of the biggest issues when it comes to a person's ability to access services, Marnie?
Well, this was really Tracie's section of the paper, so I think I'll just turn it over to Tracie.
Definitely. Tracie, go ahead.
Sure. So, we've kind of touched on some of these pieces already. So when we look at accessibility, we're looking at a couple of things. So we've hit on this a little bit about there are services and programs that will help with financial costs if we have individuals who don't have access to insurance. And that's great. But then we have other issues, and that is So for our clients in my community, getting to my office is an issue. And we often look at, okay, well, telehealth, that's a great other option. But then I have to have a client who has the ability to get Wi-Fi and to get it in a secure way that they're safe and they're able to have a session. So we'll have accessibility issues that way. The availability piece really speaks to providers and where they are. So as I was talking about earlier, if I'm the only provider in a county, and currently I am one of 3 providers in that county, I only have so many openings. I work another job full time. So I only have availability a certain amount of time. And when we have this, as we looked at those numbers Marnie was sharing earlier, we've got maybe 1 counselor serving 1,000 people. Then what does that do for your availability? You have a very hard time, I think, in any mental health office right now, getting clients in within a 3 to 6 month waiting period. I've been quoted that number here in the local area in Mankato. So then we only have 1 provider and we're trying to get lots of people in, assuming they're willing to come in. That's almost impossible to do. And the other thing is, even we have practitioners who are available, we actually kind of expect the standards for practitioners in rural communities to actually be higher, because you will treat whatever comes in your door. It's very hard to specialize in rural communities. So I technically specialize in suicide, but I have to have better training in suicide than any of my other peers in rural communities, because it's all on me at that point. I can't just easily refer out to somebody else. So from an availability perspective, we have the time issue for providers, but we additionally have the issue of provider burnout, because they're having to be so many things to so many people. And so we hit that with that issue as far as availability goes. And then again, that acceptability piece, as we've kind of touched on again here today. Is it acceptable for me as a member of a rural community to go in and access treatment? Are the providers in those areas going to understand my needs from where they are? I've told my students that I didn't know having a really thorough knowledge of sports was going to be as beneficial to me in my career as it ended up being. But I had to be able to speak a language, and kind of as other panelists have talked about, I show up at pancake breakfast periodically, because while I wouldn't do that in a larger community, I have to be seen. They have to know I exist, and not just exist, but that I'm a person they could find approachable and come talk to, and that issues in their community mean something to me as much as it means to them. And I've always lived in a rural community, so understanding those pieces are important. But the clients who are going to particularly come into my office have to know that I'm there and that I'm available. And the other thing we see with that acceptability piece in rural communities is the number of clients I have who don't even always want to walk in the office door the first time. I have people parking blocks away and just kind of nonchalantly walking through the door. And that is simply because that acceptability piece is, there's still a big stigma, or they may not want family members knowing, or they don't want other community members knowing, because they'll find that difficult. So the other part with acceptability and even the availability piece is I meet often with local leaders. So people at local churches know who I am. Local law enforcement knows who I am. So they can also make referrals. And all those pieces are kind of tied into intrinsically how rural communities function, and function in a very different way than our urban and suburban counterparts.
Is the stigma worse in rural areas compared to more populated areas in Minnesota?
I would say absolutely, but it may be better for another panelist to answer this as well, to get a different perspective.
Maybe Jinny or Andrew, are you able to weigh in on kind of what you've seen? Or
I'll go with Jinny if that's okay. Yeah, for sure. I think that the stigma has decreased in the last 15, 20 years. I think, again, the points that we have on winning over the stigma is, again, being involved. So it's like, I think what Dr. Tracie was saying earlier, as far as like being involved in the community, being visible, having open conversations with people. Even, I think, even therapeutically, I think there's an important be in rural communities, maybe not some other places, I'm not sure, but like of just being real, of even like we all have challenges. But being accessible and visible, I think, in public is a really big deal there, and it being very normalized then of it being talked about, mental health. And again, it not being something that's off in the corner, but something that's in the very forefront is very helpful, versus it being besides. I think just being involved in the community, again, is a very strong piece to curb some of that.
I'll move on to the next question. What are some of the main reasons behind the workforce shortage in mental health in greater Minnesota? Jinny, can we start with you on that one?
Sure, thank you. I think folks have touched on a lot of the reasons throughout answering several of the other questions, but I think one that is a particular focus within our organization is the mental health system as a whole. I think in Minnesota, but across the country, has historically been underfunded and under-resourced, just pretty significantly. I think we're definitely seeing now, coming out of the pandemic, that has been exacerbated because it had historically been a bit neglected and not resourced to the extent that it needed to. And now we're really seeing that start to take a toll. From our community mental health center perspectives, a lot of that has to do with trying to keep up with the competitive market salaries that folks are needing today, right? We're seeing our entire economy just going up and up and up in terms of prices, costs, inflation. And yet so many of our reimbursements for the services in these mental health care systems have been stagnant for probably the better part of at least a decade, probably longer, and especially through our government programs. And then if we flip over to the parity side of the conversation, if we're looking at equal reimbursements and equal coverage between public programs and private commercial programs for mental health, we see a huge gap and disparity there as well. So I think from a resource aspect, that is definitely putting a lot of pressure on our system to keep up and keep employees, to both recruit and then, I think almost more importantly, retain employees. This is anecdotal. A lot of our folks have said, over many years, that it used to be that they were competing with perhaps the county clinic or with the hospital or the primary care clinic, other healthcare providers in the area. And now we're seeing competition come from the Walmarts, from the Quick Trips, from the chain coffee stations and coffee shops that are popping up, who are starting to offer starting wages, $2 and $3 an hour more than what most of our provider clinics are able to offer. And so there's definitely that increased competition for a very limited population of folks. And I think especially as we're getting into greater Minnesota and rural Minnesota, the population census is just not there to begin with. And then as folks are deciding where they want to go and where they want to work, and being able to make a living and provide a comfortable life for your family is a big part of that decision making. And so I think that goes into it quite a bit. I think, talking a lot about the education side, and maybe less about the education side and more about the ability for folks to get into the pipeline and easily get to a place where they're moving through the licensing process, the training process, the supervision process to be fully licensed, credentialed, and able to practice in a clinic or independently. That, I think, is definitely something that we at the state levels, we're talking to the legislature, we're talking to our members of Congress, are really trying to find a streamlined way for folks to be able to access the industry as licensed mental health professionals, and also have a career trajectory within that. I think we have, in some ways, we've set up a system for really good reasons, for quality and for best practice and for best clinical care, a good system that is very rigorous in terms of who is able to practice. And in some ways, we don't have those entry positions that are able to attract folks and give them a career ladder if they don't come in with that already licensed position, which, for most of our professional degrees, you have to have at least a master's degree, plus a license, plus all of the supervision and hours and training in between. We don't have a great ladder or entry level stairway for folks who are coming in as an unlicensed mental health rehab worker or a behavioral health specialist, or someone who might have a degree but isn't licensed and is coming in as a mental health practitioner or case manager. It's fairly limiting, once they get to that kind of, should we say, plexiglass ceiling, to move on to that next step, unless they have a lot of other resources or some other life circumstances that allow them to get there. So I think that has been a big piece of it. And some of the work I'll just kind of finish on that we're also trying to take a look at is our non-traditional students, folks who are coming back or coming in for a second career, or have been working and supporting their family and have decided that they might have started in a mental health clinic in an unlicensed position or in an admin position, but want to continue their career and are trying to find a route to get back in as a non-traditional student who's also trying to juggle all of the other aspects of life, family, spouses, taking care of a mortgage, taking care of insurance, all of those pieces, and trying to find a pathway for those folks as well to help them also find a space in the field.
Great info. Thank you. Maybe Marnie, we'll go to you on this one, or Thad. What did the report find helpful to recruit people to their clinics in rural Minnesota?
Well, sure. Yeah. I mean, the big thing I think from the comments from the providers was that idea of being able to have more internships. And I think Thad can explain better why the internships are so important, but just being able to get the students out to the clinic in rural areas seemed to be a big help.
Yeah, if we just start big picture from a research perspective, we know, and there's a large body of literature that supports the idea that it is hard to transplant a professional from a more metropolitan area into a more rural area. And so the way in which a rural community or greater Minnesota grows their healthcare workforce is to literally grow it within. And so we have to do a better job of taking those students from those more small town areas and train them up in hopes that they'll go back to their kind of roots and provide that care. So one of the things that we learned in doing this report, as Marnie talked about, is that internship pipeline. And so how do we get more students from universities that are almost all of them at least large town or micropolitan based settings? How do we get those students placed in the Marshall, Minnesotas, in the New Ulm, Minnesotas, in the Virginia, Minnesotas? And so how do we establish those pipelines from training institutions to those rural communities? Because what we learned in our interviews was that hiring interns that did their training there is the #1 recruitment tool, more so than loan forgiveness, more so than flexible work schedules. It's really about getting someone who knows that community back home. And so how can we strengthen that pipeline to those rural areas is really going to be one of those pieces of growing that pipeline.
But
Great.
there was,
Thank you.
oh,
No, go ahead.
oh, and I was just going to say, but there is that issue of clinics being able to afford to have internships. And so maybe someone can, I mean, that's something that I think is just not well understood by people who aren't in the profession, and why that's a problem. And I was wondering
Yeah,
if anyone else could talk about that.
I wrote to that piece as well in the report, and what we're hearing from the people on the ground, and Andrew can speak to this as a clinic owner, is when you provide that clinical supervision, so when you bring in that intern or somebody who's not licensed, there is a statutory requirement for a more seasoned and credentialed professional to oversee the work of that clinical trainee. And that time of providing that supervision and teaching those novice clinicians to become more professional is not reimbursable time. And so when you're talking to small operations or nonprofit clinics that the margins are already razor thin, to take on that cost is often prohibitive. That you see in the report, Karen out in Marshall say, I'd love to have an intern, but I don't know how I could pay my bills, give my clients what they need, and give my intern a good experience. And so there are just some financial limitations in the model that one of our policy recommendation, and it's, we're not the only ones who have called for this. NAMI Minnesota has called for this, but some sort of financial reimbursement for this required supervision in order to grow the workforce.
Thank you. And I'm going to move on to a term I heard someone already mention, but that is burnout. Talking about burnout and what causes it. Andrew, maybe I can ask you that question.
Yeah, absolutely. One of the things that a lot of clinics have that we don't have, this isn't to sound self-righteous in any measure, but is having quotas that are, I believe, to be really high, and that's just to offset expenses that it costs for running business. I think one of the pieces is that there are numbers that are pushed pretty high for many of the organizations to be able to financially make it, which is then pushing the providers then obviously to be practicing probably more than they want to, or even what I would say they should be. So that I think has really led to people being burnt out just from having more clients than they probably should have in a week's time. The other piece of it too is I think what time is set aside for each one of the providers to attend to not like group therapy mental health, but being like, hey, us as providers, how are we doing? And what things can we do on a weekly basis as a group to make sure that we're on track? So I think the big piece that I think that causes the most issue, honestly, is the caseload. And I know from others in the community as well, knowing like there are they're quotas that when I hear that they have, I mean, initially I thought like, is that even possible? Honestly, more or less ethical. So I think some of it is I think push to have so many people being seen in a week's time, honestly, to be covering expenses. So, and as again, as a small business owner, I'm like, get it. And at the same time, you can't be short-sighted as well. I think the push and how hard you're pushing the providers is something that probably has been done and probably not so much of an ethical manner. My suggestion, humbly.
Yeah, Tracie, did you want to add, how do you address burnout?
So I think everything Andrew said is spot on. First, load is probably the biggest piece. But I would also, to add just to some of what Andrew was saying, is the isolation piece also comes into play, because if you're a rural provider, whether you're a clinic of 1 or a clinic of 5, if you're busy all the time, it's really hard for you to kind of deal with some of the vicarious trauma that you may be experiencing because of listening to client stories of trauma. So if we've got high caseloads and we're trying to meet the expenses, which is very common, this isn't just a rural area issue, high caseloads are typical in the mental health field. How do we have time even for our own self-care and engaging in conversations with our colleagues about, I had this difficult case? And there are lots of difficult cases. When you're in the mental health field, you're going to hear stories that are challenging for your clients, but they become challenging for clinicians as well because of how difficult they are. So definitely caseloads, I think I would agree, that's probably the top #1 issue is high caseload. And high caseload, plus you also have to get your notes done, follow up on all the other administrative pieces, and then adding to it some of those vicarious trauma pieces that a lot of clinicians will experience in the field. Both those, I think, really do add a level to the burnout piece.
And are there, excuse me, go ahead.
I was just going to chime in. Minnesota Department of Health, their 2022 workforce report dug deep into the burnout, and it is exacerbated. You want to talk about why there's a shortage. If you think about why people leave a job, often retirement is the first reason, but we are seeing an early exit in providers across mental health, primary care physicians, nurses, due to burnout. It is truly an epidemic. The US Surgeon General essentially put out a report this summer that said if we don't start correcting healthcare worker burnout, these shortages are going to be insurmountable. And so this is an important topic in mental health, but just across healthcare in general, is how do we do more to help our healthcare workforce? Because if we don't, these treatment gaps or unmet need is going to skyrocket at a pace that we definitely can't keep up with.
And excuse me, are there other health issues that in rural areas people are already facing? And really anyone could take that question. This may be more someone on the report, maybe. What other health issues do rural areas face?
Well, there's just the whole issue of just access to healthcare at all. We've done some reports on this in the past. One of the most recent ones was just emergency medical services, the ambulance, and the issues of, well, burnout, like we were just talking about with EMS people, EMTs and paramedics. There's just the issue of consolidations within the healthcare industry and the reduction in the number of clinics and whatnot. For specific health issues, I think there are just those health issues of, well, someone here could probably better answer this, but there are issues, rural people see higher incidences of cancer and cardiac issues and things like that. And probably a lot of that is down to a lack of preventive services because it's just hard to access healthcare services in rural areas.
And Tracie, maybe I'll ask you on these questions, talking about these 3 themes of what it would take to produce more licensed mental health professionals out of college and into the workforce that were identified in the report. The first was capacity limitations. The second, the cost of programs for students. And third, inadequate pay in the profession, among other healthcare industries. Let's talk about the first one, capacity limitations. How do capacity limitations make an impact?
So we've touched on this a little bit, but when we look at capacity issues, what we're looking at is really faculty to student ratio. So as a faculty member in an accredited program, and remember, as Marnie talked earlier, accreditation is really important for getting students in, making sure they're going to meet the requirements to move forward in licensure, and that once they're eligible for licensure, it's in alignment with what they need. And so we need to have accreditation, but our accrediting bodies set a limit on how many students we can have in our program. As an advisor, I'm only allowed to have up to a certain number of advisees. And particularly for our internship and practicum classes, I'm limited to 12 students per course. So at some point, we simply run out of faculty, despite the fact that we could take legitimately, I would say easily 10 to 20 more students each semester that we admit. We usually only admit in the fall, but we could probably take 10 to 20 more students who are absolutely qualified to become a professional, but we simply don't meet the faculty student ratio if we accept more. And that then hampers our accreditation, which hampers students going forward with licensure. So I think that's the biggest piece with the capacity component is we need more faculty to accept more students. And we do have more students wanting to come into programs if we're able to obtain more faculty.
If I could add one piece
Go
of
ahead.
the capacity issue. And so even beyond the classroom capacity restraints, the training sites, the internship sites that students are required to do during their graduate studies, we need more of them. We need more accessibility, particularly in greater Minnesota, for these students to do their training, to go all the way back to our first comments about if they train in more greater Minnesota areas, there's a greater chance they'll stick around and practice there. So we need not only more faculty, but we also need more clinics and more opportunities for these students to train in these underserved communities.
And Tracie, what about the cost of programs?
So the cost of programs in Minnesota averages between $25,000 and $50,000 over the course to a 2 to 3 year program, with public institutions coming in on the lower range between that $25,000 to $35,000 range, and private institutions coming in much higher. But when we start to look at, because the next question is we start to look at that pay inequity that happens, if students coming out of my program can't make as much money as we've talked about in other areas. So one of my students was remarking that partner was working for the United States Postal Service, making more money with no education than she's going to probably start out at. It's really hard to then convince people that it's worth putting in $25,000 to $50,000 over the course of 2 to 3 years to then make less money than you might make if you simply didn't pursue an educational degree at all. Most of our students come sheerly out of passion. They're so passionate about mental health and wanting to go out and provide services, but are frankly often disappointed when we have the conversation around how much you could expect to earn. And as we talk about that piece, so we talked about other health professionals. Comparable training as far as the amount of time that's spent between a mental health degree at the master's level and a nurse practitioner at the master's level, you can expect a nurse practitioner to start at around $115,000 a year. And mental health professionals on average, and this varies a little bit, about $50,000 is where they're going to end up. Some are actually much lower. Some are higher, but rarely is it much higher than that. So when we have students who are looking at, I'm going to spend the exact same amount of time in either degree category, I'm probably going to choose the degree that's going to pay me more than twice what I would make otherwise.
Thank you. And in the report, there were policy recommendations at the end talking about the best possible ways. What are the best possible ways to address these issues? And I want to talk both what was in the report, but also get your thoughts since we have all of our experts here today. So maybe Thad or Marnie, if you could talk about what you found the policy recommendations to be, and then I'll open it up to say, you know, where do we go from here?
Well, I'll just start quickly with the whole issue of pay, what Tracie was just talking about. And the question of student loan forgiveness and student loan forgiveness programs, which are a popular solution for helping get people into underserved areas. But as I learned more about this in working with Thad and Tracie on this paper, I started to realize that student loan forgiveness in this case, because of this issue of supervised training, is really kind of a backwards system, a backwards way of doing it. And it almost it makes it a guarantee and a challenge for a person going into this. It's almost like a Hunger Games kind of situation. Like, can you hold out until you get to the loan forgiveness program at the end? And whereas, a student who's sitting there looking at this going, this is going to cost me $35,000 to get through this program. Then I'm going to have to go through 2 years of low pay, after the internships where I'm not getting paid anything. And with the coursework set up where it's really pretty hard to have another job while you're doing this. And then finally I get licensed. And during this, I'm having to pay off student loans because I've graduated. Then finally at the end, I get licensed and I'm working for an underserved population. So now I qualify for a student loan forgiveness program. So it's kind of like going through this little funnel down to, am I going to finally get something at the end here? And it all sounds very, Machiavellian, but I think it's, after the student loan chaos that we've seen over the last 20 years, I think this is something that students probably really take into consideration when they're looking at this. And so can we somehow change this from a back end Hunger Games style reward to more of a front end, look, we will help you get through this. And then, it'll be worth your while because you won't be loaded down with all these big challenges once you get through it. And so that was one of the things that really struck me in the process of doing this paper.
I would concur with Marnie there. The number one recommendation, and this was a question I asked all of our interviewees, was, what would you do to make this better? And universally, the paying for tuition on the front end, having a block grant program that basically paid for the tuition of those students who committed to serving the rural and outstate communities, would entice more students into this pipeline. They may choose to go down this pathway because they know they get to have their tuition paid for on the front end. I think about my military service. I didn't join the military because the promise of a bonus on the back end. It was given to me after I signed up. And if I didn't serve my commitment, I owed the federal government back. And so not only does it work in the military, we've seen this program work in lots of other states. In the report, we cite Ohio, who recently invested $85 million into the mental health workforce by providing upfront tuition aid to encourage students to break down barriers to get students into this pathway.
We have a question that came in. It says, if funding was available for interns, et cetera, would there be people to fill the need? If anyone wants to take that one.
Yeah,
I
think from the interviews that I conducted with these outstate clinics, I think most of them, if there were some sort of reimbursement model for supervision, that if that time that is spent in training and developing the next generation of clinicians, even if there was just some amount attached to it, wouldn't necessarily have to be the full cost of that clinical hour, but some sort of incentive. I think we would see more community mental health centers and more small practices in outstate Minnesota work with training institutions to provide that training experience, which would then hopefully grow more of those clinicians in those communities. So to answer that question, yes, I think if there were funding, we would see a positive result.
Yeah, I really kind of see this as a coordinated effort where you have the funding for the colleges and universities so they don't have to turn away students, so they can have more faculty. That might be the issue, getting more faculty. But if they can get more students instead of turning them away, then you'll have more students in the pipeline for those internships. And then, you'll have more people coming out on the back end you'll have more people coming out on the back end to fill those roles.
I want to ask all of you, feel free, anyone to chime in, what happens if these issues aren't addressed? I hate to, not to say worst case scenario, but what are some of the things that you think will start to happen or will get worse if these issues we're talking about are not addressed?
I'll jump to one here. So I think, I don't know who spoke earlier about private pay. So, you're seeing a lot of people in private practice that are just taking private pay, not taking third-party payers of insurance. One, because they can charge more, and two, it's a lot easier. Which ethically, I have some challenge with that myself. But I think you're going to see people that are. I mean, we could right now close the doors to third-party reimbursers and be even in a rural community. It's like we could do that. But I think then what happens to those who are underserved already? Underserved, they're not served, period. So I look at that being that's not the full picture of it, but like that's the beginning of bigger problem. So I think you're going to see just less and less people providing insurance for reimbursed rates and for third payers. Again, then I think leads to a really bad result on health. And flooding, I think of this too. Like we talked earlier, when people are not being served, we talked about earlier, like what are the advantages for earlier interventions? I'll flip it and say if there's not early interventions, working with people who work in our local hospitals, ERs, for example, they're flooded, and they're flooded oftentimes with mental health, and that happened during COVID as well. Which is like, here it is, like you have ERs that are already completely full and weighted, and then you have mental health stuff coming in as well. So it's like it seems like a snowball cluster effect there. It's not, services aren't being provided. You're having other systems being the hospital system.
Anyone else want to add anything? No, I'll move on. For people who are watching this, or we do have some members of the media on, for people not involved in mental health, right? You're the experts. For people who don't know what's going on, but they care about this issue, what can they do to get involved, or how can the everyday person help the situation? Can they? Does anyone want to jump in and take that one, or several of you?
I think, my immediate reaction and short answer is yes, absolutely. We're always, I think if we're talking about trying to move a system and trying to move some big changes with policy or with, resources and funding, I think there's always opportunities for everyone to get engaged, to find resources for education and awareness. And then we're always looking for folks who will help us advocate with decision makers to try to make some of these systemic changes so that folks, if it's on the front end in the workforce pipeline, all the way through to very, acute hospital level care, making sure that access to that is available and everything in between on the spectrum. I think we're always looking for folks who can help us, influence folks who can really make some of these decisions and make some of these systemic changes. And so if anyone is interested, I think we're always looking for folks to help us in that space.
And I just piggyback on that awareness is the first step in solving any problem. And we hear countless stories about mental health and the mental health issues facing our communities, but the story of who provides that care has been absent for the most part up until more recently, when we're realizing, holy cow, there's this huge treatment gap. And so the more we can talk about this, and then we can tie it into what Jinny talks about, is then we can really have a louder voice to advocate for some systemic changes, for some policy changes to start to address this. Because if we do nothing, it's not simply going to get better on its own.
Thank you so much. I think that's all the questions that I have for today. I'm keeping an eye to see if any other questions come in, but I'm not seeing any new ones. With that, I'll give you a little bit of your time back in your Tuesday, your Valentine's Day. I just want to thank everyone for being on here today. This super important topic. Our panelists, thank you. The Center for Rural Policy and Development, as Julie mentioned at the top, the report came out today officially, so you can find that on the Center for Rural Policy and Development's website. For members of the media, if you have any questions or you're hoping to get a different one-on-one interview or get something clarified, my contact info was in the release that went out, but my email is kate@parkstreetpublic.com. And with that, just thanks to everyone, and please keep an eye out for events that CRPD will have coming up in the future. Thanks so much.